Hey, everybody. Good morning, good afternoon, good evening, wherever you are in the world. So glad that you're here for this exciting discussion today about integrated polygenic risk scores. And we are here in a joint effort with the American Board of Precision Medicine and MyOme. So we are really glad to have you here, excited about the discussion that we're going to have today with two of the preeminent scientists, physician scientists in this area. So very happy to have you. A couple of just housekeeping things. We will be answering questions at the end of the webinar. So if most of us hopefully are accustomed to using Zoom now, it's 2025. In the bottom, on the bottom bar, there's a Q&A section. It's like a little thought bubble with a question mark. So definitely put your questions in there. We have time at the end to address questions. So definitely want you to get those questions answered as they come up. I am Dr. Sanjay Bojraj. I'm a board certified interventional cardiologist, general cardiology, functional medicine specialist, and now adapting precision cardiovascular medicine into my practice, which is really kind of a really cool area that we're going to learn a lot about today. And I am the director of cardiovascular precision medicine for the American Board of Precision Medicine, which is a newly formed nonprofit group we formed in 2023 with the goal of setting clinical practice standards in this world of precision medicine. And really, what we're trying to do is create a bridge between the research world of all these single nucleotide polymorphisms, SNPs, and precision medicine testing, and genomics, and proteomics, and transcriptomics, which are amazing in the research space, and build that bridge for you guys, the clinical practitioners, to be able to use this in your day-to-day practice so that we can make doctors better and we can make patients safer. So that's really what we're trying to do. And as part of that, we explore exciting partnerships as we will today. I'm so happy to introduce our two panelists with us today, Dr. Akash Kumar, who is an MD PhD. His area of expertise is in clinical genetics, and he is the CEO of MyOme, and I believe founder as well. And
Yeah,
Dr.
CMO at MyOme.
CMO, okay, Chief Medical Officer, and Dr. Akil Fahed, who is just beast mode, although we just learned that he's never read the Harry Potter books, even though he's coming to us from Hogwarts. But really preeminent in his field. If you Google stalk him, just so many amazing papers in this space. So we are so privileged to have the both of you here. Thank you for being here and co-hosting this webinar with us. I guess we'll get started with you, Akash. So if you want to just go ahead and introduce yourself and share your slides.
Yeah, great. Thanks so much, Sanjay, for that introduction. Let me get started here. As Sanjay mentioned, my name is Akash. I'm a clinical geneticist. I have an MD PhD degrees. My background is in genetics, and I have a practice at Stanford where I see mostly children and adults with rare diseases. But over the past 5 years, we've been building MyOme, which I think it's really exciting to be able to present to the Board of Precision Medicine on because we seek to be leaders in predicting and preventing disease. And the platform that we're building, which is based on a whole genome, provides not only information on rare diseases, which is the predominant population I take care of, but also some of the most common, impactful chronic diseases that affect Americans, like heart disease, diabetes, and a number of cancers. And so it's a real privilege to be able to be here because I think that the platform that we're building is really the foundation for what we see as the new way of predicting and preventing disease. And I think there's no better place to start than coronary artery disease. So with that, let me get started. I think this audience is no stranger to the fact of the impact that heart disease places in the U.S. It is a leading cause of death in the United States, with over 370,000 people dying from either heart attacks or sequelae from heart attacks in the U.S. One of the most challenging things that I've heard from cardiologists and internists is that is the most problematic areas are the scenarios where the heart attacks are kind of flying under the radar, where there's a substantial elevation in risk in a population that may not have the conventional risk factors like high cholesterol or other kind of smoking, other lifestyle factors that may contribute to disease. And I think this is a real opportunity for precision health and more targeted prevention strategies. Some of this stems from the fact that the traditional tools that we have for predicting disease, like the AHA, ACC guidelines, categorize people based on 10-year risk into the low categories or the high-risk categories. But you can see there's a substantial population in the middle where there's a borderline or intermediate risk where the decisions on whether to start statins or be aggressive on lifestyle interventions is really up to the patient and the provider and conversation. And although there are tools like the risk enhancers and other tools available, these tools largely ignore the impact of genetics, which is a really outsized impact. There are a number of typical risk scoring tools which are available, like the Framingham Risk Score and the ASCVD Risk Calculator. All of these estimate either a 10-year risk or a lifetime risk for heart disease, but importantly, these do not account for for family history or other genetic factors, which can really drive a person's risk for heart disease. And so this is the real opportunity that MyOme has been, and MyOme and others have been interested in solving because of the outsized importance that genetics plays in heart disease. Between 40 to 60% of heart disease and coronary artery disease is heritable, which means genetics plays a really central role in someone's risk for disease. But the fact that it's missing from conventional risk calculator means that this is probably a large fraction of those people who are flying under the radar and developing heart attacks even without the conventional risk factors. One of the challenges with genetics in the traditional sense, those genetics like that impact single genes like BRCA1, BRCA2, is that while each of those individuals that carries a single gene, for example, in familial hypercholesterolemia, may have a really strong risk for heart disease, in reality, that's the minority of people that develop heart attacks and heart disease. And so there's a substantial fraction of heart disease that's genetic, but missing from those traditional tools. And this is where we've seen a lot of interesting developments over the past 5 to 10 years that MyOme and others have been part of. And that development has been the development of tools that can access and assess an individual's risk for heart disease and genetic basis of heart disease by looking at not just the single gene components, but something different, and that's called a polygenic risk score. A polygenic risk score is essentially the aggregate effect of many, many thousands or even millions of different locations in someone's genome that each individually contribute a small amount of risk, but collectively, when summed together, create a much more substantial impact on an individual's disease risk. There's a lot of nuance in the process of computing these scores that we'll get into later, but you can think of it as a single metric that can assess someone's genetic risk for disease. And we know from prior publications that these genetic estimates actually play a really strong role in predicting disease. You can see here a paper that came out in 2018 looked at the impact of polygenic risk scores compared with other conventional risk factors like smoking and diabetes and family history. And you can see this plays a more of a role in an individual's risk for heart disease than those conventional risk factors. Importantly, it's also present from the time of birth, which means unlike some of the imaging findings or smoking or other exposures, this is an exposure that lasts over a lifetime, which adds and aggregates the impact of this risk factor. It's not all bad news, though. As you'll hear in Akul's talk, an individual's polygenic risk score also can predict an improved response to certain therapies like statins, an improved response to lifestyle modifications, and finding out an individual's risk for genetic risk for disease actually is associated with a stronger likelihood of uptaking some of these interventions like statins and lifestyle modifications. Some of this information has gone into a really strong scientific statement from the American Heart Association, which came out several years ago, which highlighted some of the evidence in this area, including some of the benefits on choosing statins, impact of statins, and lifestyle modifications. This scientific statement also called out certain challenges, including the fact that polygenic risk scores historically were based on pretty large databases of European individuals, which made the applicability across multiple ancestries less strong. And so this has been one of the areas that this scientific statement called for, and an area that MyOme has taken a very strong approach to. Let me walk you through how we are approaching polygenic risk scores at MyOme and what we've done to support this. First and foremost, we've been developing polygenic risk scores and tools for these polygenic risk scores that are relevant across multiple ancestries. This requires some adjustments in the method of computing these polygenic risk scores. Specifically, we use thousands or hundreds of thousands of markers now that can decompose an individual into multiple different genetic ancestral components and use that information combined with multiple large multi-ethnic studies to essentially develop a more powerful genetic risk predictor that can be relevant across multiple ancestries. Another key approach to another key aspect to our approach is that all of our scores are validated across multiple ancestries, and we've taken pains to access biobanks and other information, other large clinical resources from the US and across the globe to be able to do this validation. We've taken an approach of being able to develop pretty comprehensive methods of looking at someone's genetics. Using a genome backbone, we can substitute and include the latest approaches, as well as the most number of risk alleles in our polygenic risk models, which has been a real strong advantage of our approach. And then finally, by incorporating clinical risk factors, we're able to not only account for a really strong component in modifiable risk, think heart disease, think cholesterol levels, smoking status, BMI, real factors that primary care providers and cardiologists can engage with their patients on, but also by incorporating clinical risk factors and computing a 10-year risk, we fit within the traditional paradigm of clinical risk prediction and risk stratification by computing a 10-year integrated risk. And so these are several aspects that really distinguish MyOme's approach relative to others. These approaches have been published in a variety of top journals, Nature Medicine, JCO Precision Oncology, as well as a number of different conference proceedings and other situations, other poster presentations along the way. And we're really excited to say that our polygenic risk score approaches have now made its way into multiple different products, including one focused on breast cancer, as well as one focused on coronary artery disease, which we released in the last week. So over the next couple of slides, I'm going to walk through this approach in a bit more detail. At a very high level, what we're doing is we're taking, again, clinical risk factors like you'd see in a traditional clinical risk predictor. We're combining that with over 1 million genetic variants and so aggregating that into a polygenic risk score. And then we're taking these two independent factors and combining them into what we call an integrated risk score estimate. And so in the process of doing so, we get two numbers that a clinician can act on. The first is a traditional 10-year risk for coronary artery disease, and the next is a integrated risk score that accounts for that genetics. And so what you're going to see in the next few slides is the result of a clinical validation that we've done in working with large biobanks to really show how well our test works. And to really validate our approach, we rely on a pretty unique resource, which is large research repositories of individuals who've contributed their genetic information as well as clinical information, and 10 or 15 years of longitudinal follow-up from the time of sharing that information. And in doing so, we can ask the question, what fraction of people may start off in this intermediate or uncertain range that might be upgraded into the high risk range? And we can actually follow those individuals over time to see the impact on ultimate outcomes of coronary artery disease and other diseases. And what you're seeing here is one of several sources of evidence that we've done to validate it. In the red, you're seeing those individuals that have been upclassified from being in a borderline to intermediate case. And in the blue, you're seeing those individuals that are being downclassified. And there's two things I want to point out here. One is really this dramatic separation between these two lines, showing that there's a strong enrichment for disease in those people when you include genetics. And this strong enrichment in disease is invisible unless you have access to that genetic information. And the second thing that I wanted to point out here is the fact that we validated this not only in a predominantly European cohort like the UK Biobank, but several other repositories of multi-ethnic individuals, including MESA and ERIC, which are based in the US, with very similar results. The people that are upgraded in risk have a much higher rate of disease. Most recently, and this is work that's currently been accepted at NPJ Cardiovascular Health and will be coming out in a few weeks, we've seen also within a US-based cohort, this is a collaboration with UPenn, Dr. Dan Rader and Michael Levin, we found that in a pretty diverse US-based hospital cohort, which has over 20% African Americans, we see about 10% of individuals in that borderline to intermediate range being upclassified to having a threefold higher risk of disease. And I think this is something that's quite powerful to us because it represents that not only are polygenic risk scores relevant, but they're relevant to the majority of individuals in the United States who could really benefit from this information. And this is coming on the heels of more and more data that suggests that clinical risk scores, like the pooled cohort equation and the Framingham risk scores, do not perform well for individuals of diverse ancestry, giving it another reason to include genetics in our risk predictions. So we're very excited to see this science and this validation. We've taken these results and we've applied them into the product that we've launched in the last week, which is really a genetic tool to predict rate of disease. And just to highlight a potential use case of this, and Akka will go into more of these in his talk, you can see as one case example, a 46-year-old who may present to the clinic with a moderate LDL cholesterol, 136, who aside from being treated from hypertension has very few risk factors for heart disease. This is exactly the individual that we want to be able to help, because their clinical risk scores by themselves may predict only an intermediate risk, 7.6%, but they may have a latent genetic predisposition to disease that's otherwise missed from these traditional tools. And so the outcome we'd like to prevent is obviously this person developing a heart attack. And by using MyOme's tool, which again incorporates clinical factors and this polygenic risk score, we can identify that that individual is at high risk for disease and treat them accordingly. More aggressive education, more aggressive lifestyle changes, a higher dose of a statin that will make sure that that person follows. And again, this is exactly the scenario that we're trying to encourage, which is more precise prediction and prevention of heart disease. Our reports, which support this effort, are fairly straightforward. You're seeing an example of the report here. It's pretty simple and easy to use. People are either classified into the high risk or not elevated risk based on their genetics and their clinical risk factors. We provide both the clinical risk as well as the integrated risk scores as part of this process. And just one thing I want to highlight here is, when most people think of genetics, they think of something very complicated, autosomal dominant, autosomal recessive, a lot of genetic counseling associated with that. We've taken a lot of effort to be able to make this as simple and as user-friendly as possible. This is something that a primary care doctor, an internist, or a preventative cardiologist should be very, very comfortable in using, because it's simply integrating within the traditional risk score framework. We'd love to be able to get this test out in people's hands. One other unique aspect of working with MyOme, remember at the top I talked about us building a platform for information over someone's lifetime. Because of the tools that we've used, both in reading the genetics as well as the platform of reporting we've developed, anyone who gets our coronary artery disease report will also have the opportunity to avail themselves of multiple other reports. Here's an example of other reports that are currently available or will be available soon in our proactive health panel. This includes traditional genetic risk panels that test for single gene conditions like BRCA1 and BRCA2 that carry with it a high risk for either breast cancer or other genes involved with heart disease. We've got a whole separate panel focused on pharmacogenetics, which impact over 70 medications, as well as other integrated risk models. We talked about coronary artery disease today. We've heard a lot of interest also in our type 2 diabetes integrated risk models, which will be launching soon, as well as our breast cancer integrated risk score, which is available currently. One thing I want to highlight here is that the fact that you're on the platform means that we can return this information much faster than we could otherwise. For example, you can get a pharmacogenetic report in days and maybe even hours in the future. And we can also provide this in much shorter time frame. So instead of waiting weeks to get the results back, you can get that information much more quickly, because we have access to someone's genetics and we can pull these reports down in the future. So again, the vision of MyOme, I think, aligns very closely with the vision of precision medicine, which is a physician should be able to easily access information that's relevant for a patient, not only for the disease that they're in for today, but also other conditions in the future. And that's really what MyOme's platform provides. We've taken pains to make it simple to order these tests. We have a portal where a physician can order the test. A saliva kit or a buccal swab, which is a cheek swab kit, gets shipped directly to the patient's house, and the report returns back to the physician. And again, genetic counseling is something that we think most folks feel very comfortable without, but we make available in those situations where this information is relevant. We've got a lot of research ongoing on ways of improving these polygenic risk scores even further that I'm happy to talk about in the break. Some of these approaches use EHR information to improve the risk prediction even further. There's also a number of clinical trials we're engaged with to improve the accuracy and improve the reimbursement of these tests. But with that, I just want to conclude by saying that the fundamental approach we discussed here is an approach that combines genetic information with clinical risk factors. We're doing an integrated risk score, which fits within the traditional framework of how we currently assess and prevent coronary artery disease. And that by including this, we're really addressing a gap that exists today, which is that traditional clinical risk tools miss those who develop coronary artery disease. And you can see that our platform here enables a bunch of different reports over someone's lifetime. So with that, I'm looking forward to seeing the clinical use cases that Akil will describe. I'm happy to take questions at the end.
Thank you. That was absolutely fascinating. And it reminds me, as a cardiology fellow, first or second year, whatever it was, one of my attendings, this is how ancient I am, right? This is just around the time where these risk-based assessment tools were being used. Before it was just kind of that gut feeling, of the cardiologist, oh, I wave my magic wand over you and I think that you're going to have cardiac disease. But, one of the things that was impressed on me was, the function of the cardiologist in particular is to pick that needle out of a haystack, right? You've got a low risk patient population, but in that low risk group, 5%, 1 out of 20 people will be the one that goes on to develop cardiovascular disease. So we have to sharpen our clinical acumen to be able to predict who that one person is going to be, right? So and we would do stupid things like earlobe crease and all these clinical signs, of trying to pick those people out. But this really now is adding science back to that art, and I think it's absolutely fascinating. So
Yeah, I agree with
wonderful.
you. It's a great opportunity for precision health, really a great
Yeah.
opportunity for precision health.
And amazing. Just a reminder to everybody, we're already getting some amazing questions in the Q&A. We definitely want to get to those. So in the Q&A section, not in the chat, please put in any questions that you may have. Like I said, we do have time at the end to discuss those, and we definitely want to get to those questions. It is now my pleasure to introduce Dr. Akal Fahed, who is just super nice guy and very smart and runs Fahed Lab. As you will see, he'll introduce himself, but just a wealth of information about integrated polygenic risk scores, and that's everything I have to say. So go ahead, Doc.
Thanks, Sanjay, and really glad to be here. Thanks for the American Board of Precision Medicine for the invitation, and congrats to MyOme for launching their coronary disease integrated risk score. As Sanjay mentioned, I'm a cardiologist, also myself at Mass General Hospital here in Boston, and I run a research group that's at Mass General, Harvard, and the Broad Institute of MIT and Harvard. And a lot of our work is focused really on developing new methods for polygenic risk scores and also implementing polygenic risk scores in clinical practice. I do have some disclosures to share, including consulting for MyOme here, so very familiar with their product. What I want to really share is really try to broaden the perspective of how we think about the clinical application of polygenic score. And one way to think about it is that we view that polygenic scores have clinical applications throughout the life course of the individual. And a lot of what Akash shared really falls into that bucket of middle age, where we already have some clinical risk factors for disease, and you can improve the precision and risk estimation by combining or integrating clinical risk factors like high blood pressure or age and smoking or LDL cholesterol that are part of the pooled cohort equations with the polygenic risk score, and can definitely improve the precision and risk estimation. That is one clinical use case that's right there in the middle of that slide. However, I want to convince you by the end of this, those 15 minutes and share some case presentations that there is also clinical application to the left of side and of that and to the right of that. So there's clinical application for early detection even before the onset of clinical risk factors with genetics alone. And then on the far right of this slide, there's actually, even after people develop coronary artery disease and come to my attention as a cardiologist, there's also even still utility and value for genetics and actually predicting recurrent events even later in life that might help with intensifying treatment decisions. So again, precision medicine with the use of polygenic scores across the lifetime of the individual here, from early life until late after development of disease. So why don't we start with the first case? This is actually a real patient that I saw. It's a 38-year-old man who was completely healthy and fit, goes to the gym, had an annual physical a few weeks prior, was given a clean bill of health until he came in with a crushing chest pain. And for any cardiologists in the audience, this is what we call a cardiac catheterization. We wake up in the middle of the night. If someone has a blockage in an artery, that's what a heart attack is. What you see here is dye flowing in the artery. This is the right coronary artery, and there's a sudden stump here. And this is, if not treated, most of the time it can cause sudden cardiac death. So we open up that vessel. And in this case, saved the life of this individual who all of a sudden, again, pretty young, no risk factors, had a myocardial infarction. This, unfortunately, is still too common. I practice as an interventional cardiologist, and I can tell you that every a month or so, I actually see a patient similar to this one who has kind of no risk factors, pretty young, and has a heart attack. This patient the next day asked me, so what caused my heart attack? Every patient will ask that. And often what we're looking for are these risk factors on the left side, your blood pressure, your cholesterol, family history, etc. And in fact, for this particular patient, he had none of those. All of those checked in. He's kind of healthy. You go one by one, and they didn't. So that's really when we start thinking about genetics. And genetics, as Akash explained, coronary disease is 40 to 60% heritable. So it's enough sometimes alone to actually cause a heart attack. And when we think of genetics for coronary artery disease, we think a lot in terms of monogenic risks. This is where you have rare mutations in genes that cause elevated LDL cholesterol, a condition called familial hypercholesterolemia. But more commonly, you have a polygenic driver of coronary disease, which is really the subject of today's discussion. And in this case, actually, this participant ended up having a high polygenic risk score for coronary artery disease that was not known before. And in this context, according to current guidelines and practice, would not have been treated or detected. So there's one editorial that was written on the subject by one of my colleagues here at Mass General, Dr. Nanarajan, that really called it the first risk factor. And I think that's a very important thing to recognize. This is a risk factor that's present from time of birth, and when people have it, it indicates an exposure of that risk over the lifetime. So it's kind of important concept to keep in mind as we think about genetics. The fact that this is kind of relatively new compared to clinical risk factors, it does not reduce the importance of that risk factor. It is a risk factor by definition. We are born with those genes, so it is present with us from the time we are born. So it is the first risk factor. And there's been actually studies looking specifically at patients similar to mine, the one that I presented. And that's from a paper that's coming from one of my former mentors, Dr. Kara, in 2019, that looked at people with premature coronary artery disease. And basically, for every 100 people that have premature coronary artery disease, about 2 have a monogenic condition like familial hypercholesterolemia, about 2%. That's higher than the general population, which is about 0.4%. But about 20% actually have a high polygenic risk score that really results in the same increase in relative risk. So again, this is important to highlight that actually it's not a rare issue; it's a common issue. So the impact of that in our clinical practice has the potential to be actually quite large. When we think, often we're asked, well, we understand that you can stratify people with high genetic risk alone, but can't you just tell if you're looking at other things like LDL cholesterol? And in fact, you can't because it is an independent risk factor. So this is a good illustration of that on the right side. And again, this is published in 2020. When you look at people who have a monogenic disease like familial hypercholesterolemia and you compare the LDL cholesterol, they're going to be much higher than people who don't have that mutation. But when you look at polygenic risk score, people who don't have high polygenic risk score versus people who do, on average, statistically, you'll have a signal for elevated LDL cholesterol, but in fact, you cannot pick them from a bunch. If you give me 100 people and give me the LDL cholesterol, I cannot tell who has a iPRS. This is an important concept, and Akash used this word, it's flying under the radar. These are truly people who otherwise could be missed because this is an independent risk factor that is also additive, as Akash explained, that we'll get a little bit to that. Now, an important thing here to highlight is that this is not just about identifying these people. You could actually do something about it. And there's multiple lines of evidence that now actually support 2 areas where you can actually intervene and lower people's genetic risk. The first one is the lifestyle modification. We have robust evidence from a lot of existing data from large cohorts at this stage. This is the figure here highlighted is from the first paper on that subject in 2016 in New England Journal of Medicine that basically demonstrated for people with high genetic risk, if they have a healthy lifestyle, the risk is actually half of those that don't have a healthy lifestyle. So what that means is for my patients who have a high polygenic risk, it does not mean that they are doomed or they cannot do anything about that risk. They actually can cut that risk by half if they actually adopt a heart healthy lifestyle. So that remains the cornerstone of management, and it helps us focus the intervention on reducing the risk. The second thing that we could do is actually lowering their cholesterol. And there's multiple analyses of both statin trials and PCSK9 trials that actually have demonstrated that you can markedly reduce the risk of coronary artery disease and myocardial infarction using these lipid-lowering medication. And the effect and the benefit is even higher in people who have a high polygenic risk score. And I think that's an important concept. So definitely you can improve and lower that risk by starting a lipid-lowering medication. And the last thing I'll highlight here is that we do have now imaging technology that actually will allow us to visualize plaque buildup in the arteries way before it leads to a heart attack. And there's a lot of data now demonstrating that many young people actually are living with this plaque that's kind of subclinical and might not know about it. And we know that the polygenic risk score is strongly associated with the presence and the severity and the characteristics of plaque from multiple studies that are highlighted here on this slide. So that was one of the rationales where we actually launched a clinical trial in 2023 that's now actively enrolling. It's called the PROACT clinical trial, where we're actually identifying people with high polygenic risk score and conducting coronary CTs to find plaque and try to reverse plaque prospectively. We anticipate this trial to be out in 2027. So I've given you the example of a patient that is on the left side of the spectrum, where really genetics was the only marker actually, and the high polygenic risk score was kind of the starting point for them. Now you have a patient who has some risk factors, a 59-year-old white female who has some risk factors. She's a former smoker, hypertension, has an LDL of 145. And it's interesting, you look at this patient, and actually if you use the PCE, pooled cohort equations for risk calculator, it will give you that she has a borderline risk. It is 5.3%. So according to the guidelines, if she has really no risk modifiers, she actually might not get a statin. There might be a discussion around that. So this is really where the value of an integrated risk score, such as the one that Akash presented, actually, could be beneficial to either, help us understand, is it okay to de-risk her, not start a statin, or should be up risk and her risk is actually higher? And there's a lot of data actually that supports that. This is just one example of that. When you look at the pooled cohort equations by different strata on the x-axis, there's a stratification by genetic risk. And then when you look at pooled cohort equation versus polygenic risk scores, they both are actually pretty highly predictive and have a good discrimination for coronary artery disease, but the best discrimination that you get is by combining both. And this is, again, one example of numerous papers on that subject that pretty much demonstrate the same. One last kind of component to highlight here, the component of age also matters. This is a recent work from our group that we published in earlier this year in January, that basically demonstrate that the value of adding a PRS to clinical risk, such as the pooled cohort equation, is higher at younger age groups. So when you start in 5-year increments from 40 to 75, it is highest at the age of 40 to 45, 50 to 55. But it is present throughout the whole scope of age, essentially between 40 and 75. So again, when you have a 45 or 50 or 55-year-old, this is where you're going to get the largest benefit. But the benefit is present throughout the scope, that trajectory of the life course. And then back in about 3 years ago now, we've implemented actually this model in clinic at Mass General Hospital. And there's one paper published on that regard. We've actually disclosed the monogenic and the polygenic and calculated pooled cohort equations in a context of a preventive genomics clinic at MGH. We've actually demonstrated that this approach is feasible in a clinic and also results in actually significant change in management. In this small study, it was about 40% of people that actually resulted in a change of management because of this implementation of a combined clinical and genetic risk assessment in the context of a clinical setting. So again, demonstrating that this actually could result in a change of management. And this is focused on the pharmacologic and imaging management, not even including lifestyle management and intensification of lifestyle approaches. I want to end with this last case. I'll take 3 minutes just to cover this last case to really also convince you that even when people have coronary artery disease, and then on the far right side of the spectrum, genetics is actually still valuable. And this is a subject area that my lab is actually very interested in because most of my practice is actually seeing patients who already have disease. So this case is a 62-year-old man, has multiple risk factors, already has coronary artery disease, had a myocardial infarction, had actually a blockage in one of his arteries and had a stent placed. He started on aspirin and clopidogrel. He's already started on high-intensity statin. That brought his LDL from 150 to 87 milligram per deciliter. He has a normal lipoprotein A. And I think the key question here, does it even matter at this stage? Does actually knowledge of the genetics play a role at all at this stage? And what I would like to convince you is actually that it does. And there are 3 data points, all within the past year, that came from our group here at Mass General and the Broad. The first paper came from Dr. Cho and Dr. Nanarajan's lab that basically looked at the UK Biobank and asked the question, if you take everyone who has coronary artery disease and look at all the predictors, genetic, clinical, sociodemographic, how do they rank in terms of their ability to predict a recurrent event? So everyone here has coronary artery disease. What's the best predictor for a recurrent event? And guess what? Coronary artery disease polygenic risk score ranks the highest among them all. This is ranked from top to bottom. You have CAD PRS, HDL, AGIT for CAD. Still a large proportion of actually that relative risk of recurrence of an event is driven by genetics, even with treatment and even with knowledge of all the other clinical risk factors. So that was the first data point that convinced us that genetics plays a role. The second data point is work from our group in collaboration with a group at Amsterdam UMC, where we actually looked at a cohort of people who had a coronary CTA 10 years apart. And we asked the question, does actually genetics predict progression of plaque over time, even if you adjust for the severity of plaque at baseline? So if you take 2 patients here, one with high PRS, one with low PRS, and you say, I want to adjust for whatever plaque they have at baseline, does plaque progress faster in those with high PRS? And it does, which is again fascinating. It just indicates that this genetic exposure continues to lead to rapid progression of disease in patients. And then the last point is actually a work just published by 2 fellows from my group, Dr. Supriyami and Urbut, a few weeks ago in JAMA Network Open, that actually looked at people who have a cardiac catheterization and had a stent, so similar to that patient that I just presented. And genetics is highly predictive of coming back for another angiogram, having revascularization. And when you put a stent, it was associated, the polygenic risk score was associated with a 3-fold increase of that stent actually getting blocked over time, which is really an important driver. So if you put a stent and it's actually, there's a driver that actually going to increase the risk of actually the stent getting blocked and then needing another stent, it might change your perspective on how aggressive you might want to be with treatment in this case. And I'll end with this comment on, how do we view genetics as we move forward? It shouldn't be about a single measure, like a single polygenic risk score. We should be building infrastructures that actually would enable the genome first approach, where for a single patient, as clinical need arises over time, we're able to interrogate other genetic markers. So in the case of this patient, they had a stent, they are on clopidogrel. It is quite important actually to know what their CYP2C19 genotype. So if this is available on a platform, that makes it extremely important to actually learn that information about them, because it could have impact on their management. It might have not been important when they collected the genetic data a few years ago, but at that time it becomes available. So it's important to think about platform approach to actually having genetic data available for the clinician. And with this, I'll wrap up. I'm going back to my summary slide, and hopefully I've convinced you that really genetics plays this role throughout the life course of the individuals.
Thanks. That was awesome. I need a moment to just process all that information. It was a lot of things. Super helpful. We are open to Q&A, but I'll get the party started here with a few questions, and then we'll get into those that are coming in through the Q&A. So you mentioned, and I love that slide about decade of life versus risk, and really kind of in the 40s is where, conventionally as an interventionalist, we say, that's when you've had enough time to accumulate enough plaque to really start having kind of significant cardiovascular outcomes. So when you think of the ideal time to start testing, right? Because in theory, your genome never changes, right? Like you have the same genome on day 1 of your life as you do on day n-1 of your life, right? But we wouldn't necessarily recommend genetic testing for cardiovascular disease in someone who's 3 days old, right? So in your practice, when, we mentioned kind of these ideal patients, but when would you say you would start that discussion about, hey, you know what, let's check this integrated polygenic risk score and start to get a better sense of what's going on? And, how much of a difference would you see at age 40 in the same individual as if you check it in age 45, 50, and so on? So is there a role to be checking it multiple times as those quote unquote modifiable risk factors may change?
I'll let Uncle take it.
Yeah, I'll take a stab at this. I think this is an important question, right? Like when do you actually test and in what patient, right? In essence, this information could potentially be valuable in every. But at the end of the day, when you're working with a patient, you really want to ask the question, does it matter if I know? And that's what I ask myself every time I'm seeing a patient. So if a patient is already maxed out on all, I know they're high risk and they're maxed out on everything that I can do, then probably there's no point in knowing, right? If I think that actually knowledge of some increased risk is going to change what I do, then I go ahead and test because I think it's quite important. Now, the interesting thing in cardiovascular disease, both primary prevention and secondary prevention, is that actually most of the time you could do something more. And that's because of the beauty of how much this field has developed. We have multiple medications to actually lower cardiovascular risk, right? Lipid-lowering medication, you have GLP-1 medications, you have digital solutions for interventions. There's a lot of things that you actually can do to lower someone's risk. So in my mind, if I need any additional data point to drive whether it's patient adoption or patient being convinced that they should do something about it, or whether it's prescription medication, then I go ahead and test.
Yeah, no, I love it. And just a shout out to Diet and Lifestyle. It's actually funny that 2016 New England paper from Dr. Kara actually changed my career. And that's what I do now as I run kind of aggressive diet and lifestyle programs because as you know, in the conventional world, we're just not taught that, right? So I think, I love that and we get into the epigenetics. So
Yeah, that's right.
to kind of
Absolutely. Maybe if I can just jump in on what
yeah, please do, please do.
Akil said. I think we fully agree with Akil, and I think that we want to be, as MyOme, we want to be supportive of building the infrastructure to be able to ask these questions when it comes up. Like you mentioned, that pharmacogenetic question came up after the person developed heart disease. Well, we'd like to be able to set up that patient right up from the start to get the information on their coronary artery disease risk, and then subsequently to get that information for pharmacogenetic information when it matters the most for that patient. So that's the first concept, which is that we're building the platform to make this information available over time. Another piece that I think Akil touched on briefly, but I just want to reiterate, is the fact that we have the genetic information as well as these modifiable risk factors at the same time. And so when someone joins the MyOme platform and they get that coronary artery disease risk score at day, let's say at 40, and they find out, you know what, actually they're at borderline risk still. No need to worry at the moment. Well, they can come back the next year. We can rerun their genetics, we can rerun their clinical risk factors, and we can recompute an integrated risk score. And so you have that information following you over your lifetime. So even if it isn't relevant on day one, which it may not be for the majority of people, especially in younger ages, that information will be available over time. So I think that's the other really nice aspect about building that platform, is that information is available on an ongoing basis.
So you're checking the genomics once, but then you're changing those modifier, and that's the I of iPRS, right? The integrated polygenic risk score.
That's
So
right.
as your modifiables change, you don't necessarily have to be resequenced or whatever, but you can add that new information, updated information. So in fact, you get an annual recheck of your risk, and then because in clinical practice, for instance, I'll have a lot of patients that say, what I was sailing fine until about 44 45 years old, and all of a sudden everything happened, right? And then I turned 60 and like everything else happened, right? And so there's certain 44 and 60 seem to be these times of genetic switches turning off or on, so you could actually kind of follow them then and
Absolutely.
get a sense of, hey, you know what, you just turned 45 for your 45th birthday, I'm getting you a statin, right? Like you can make those changes. And I think that's an important discussion, an important point. And getting back to, I think, some of the stuff that maybe when we're ordering polygenic risk scores, people don't realize is, I think, the importance of having the different cohorts of patients that you're comparing to. Like for years, when the Framingham score came out, I said, look, this is your risk if you're a Caucasian person living in Framingham, Massachusetts. I don't know what it means if you're Indian and in the United States like I am, or for that matter, if you are of mixed ancestry, right? You have a parent who is Caucasian and a non-Caucasian parent or whatever. We don't have a lot of that information because it has been clean. So I think, let's maybe talk about that for a moment here, and why is it important that we don't just have one database, but we are looking at like these multiple databases where we're getting kind of a larger pool of people from different ethnicities to really inform that decision about cardiovascular risk.
Yeah, I'll
Akash, you want to take that? Yeah,
sure,
happy to
sure.
take a stab. I mean, I can talk about genetic ancestry, and I think maybe it would be interesting to hear how MyOme has approached that problem. I think there's with genetics, I think the interesting thing is what you're touching on, Sanjay, is there's two components, right? There's genetic ancestry, which is really, are there biological components related to genetic ancestry that could import risk? Is there a variant that's more or less common in one ancestry or effect size that actually different? We know these exist. There's multiple methods that actually today could correct for them. With expansion of larger and larger data sets, it's quite important that these have the most representation, from all over the world to actually detect genetic ancestries. And as you mentioned, this is, I think, our view these days on genetic ancestry is that this is not necessarily a buckets. It is more of a continuum of genetic ancestry. And, both, you can look at continental and subcontinental groups, but then you can also look at mixed genetic ancestry. So the solution there is a lot of methods that have been focused on really improving that representation in large data sets, but also in methods of actually how you calculate and derive these polygenic risk scores. So I think that's one component to it. The second component is really around understanding risks that come with different racial groups that are really related to socioeconomic factors, sociodemographic factors that are not necessarily related to genetics. And I think it's quite important to break down that. You mentioned the example, obviously, of South Asian community in the US, and clearly being South Asian alone is actually a risk factor for coronary artery disease. That's very well studied now. There's groups in NIH funding actually specifically dedicated to understanding that risk and how do you mitigate it? That might not necessarily always be related to genetic ancestry, but might have other components to it.
Yeah, great. No, thanks, Akal. I'll just add to both of the points that Akal made. On the first point, which is a genetic ancestry component, at MyOme, one of the key aspects, as I discussed in the slides, has been being able to access the most information on an individual patient, as well as methods that can take that information and basically essentially break up an individual into their ancestral subgroups. And so this issue that Sanjay, you brought up of someone being admixed or someone having one parent from one genetic background, another parent another genetic background, if you use very simple approaches for genetics, you'd be completely confused. Because you don't know where to place that individual in terms of their genetic risk. And so one of the areas that we've covered, and actually I can point people to our paper in JCO Precision Oncology as an example, is addressing exactly that, using as large of a genetic database as we can, as well as deep a genetic profiling on an individual as we can, to essentially place that individual and relative to other ancestral subgroups. We use about 5 ancestral population subgroups in our analysis. And we use that information to essentially more accurately pinpoint that individual's genetic background and adjust for that in our polygenic risk scores. So that's the first point that I'll address, which is just one example of the genetic background and the approach that we use at MyOme to correct for that. On the second piece, I think Akal brought up a really good point on the socioeconomic factors and the other aspects that can contribute to someone's risk. Kind of 2 points here. One is, we found that the traditional framing hands and the pooled cohort equations, I think everyone here would agree, do not represent some populations very well. And actually, that's an area where we saw some of the best improvements in our integrated risk scores. The Hispanic population, the South Asian populations saw the most improvement in the reclassification of individuals, so that appropriate cases are appropriately being called as cases. So that's one piece, which is a very simple improvement upon clinical risk predictors that comes from our approach. But the second is, I think that social determinants of health plays actually more of a role in disease risk than we probably give it credit for. And that's where a continuing research on MyOme is adding more and more information, either from self-reported data or else information in the EHR, that I think will continue to improve the process of disease risk prediction. That's not part of our initial product, but it will be part of a future product. So stay tuned.
Well, yeah, and that's great. And that actually gets into one of the questions, a couple of the questions that we're being asked by the audience is, number one, like a lot of the stress response and the social determinants kind of affect not just our genetics, but the epigenetics, right? So how do we integrate kind of the epigenetic changes? And maybe we can just at a high level describe what epigenetics is for those in the audience who might not know. And is there a way to integrate that into the risk score that we're calculating here? Akal, I'll give that one to you.
Yeah, no, absolutely. So I think this is a very important question, right? Like, how much do we think is related to germline variation? These are variations that you're born with, but also gene-environment interaction. So, modifications in your genes or susceptibility to modification that is related to environmental factors. And the other thing that we didn't talk about today, also there's impact of somatic variations that actually lead to clonal hematopoiesis of indeterminate potential, which is also a known driver of coronary artery disease.
Calm down, brother. You're losing me. So there's different factors. In other words, there's kind of what you're born with. and then there's what happens after you're born, changes that are made to your genome, right?
Absolutely, absolutely. So there's, the way to think about it is that there's what you're born with. There's and that has an impact on your health. There are germline variations that you're born with that might not have an impact or might have an impact depending on what you're exposed to. So the impact of those depends on exposures that you are exposed to in your, for example, a variant that might only be relevant if people are smoking or live in a polluted area, but that might be less variant if you don't. So we call these gene environment interactions. And then there's a third component that is somatic variation. So these are changes in your DNA that actually happen, you're not born with, but happen over your lifetime. We know that there's a strong role for all of those actually in coronary artery disease. So I can just point maybe to one of the pieces of work from my group that we recently published. We're doing efforts to integrate those into more clinical risk scores. So I think what MyOme demonstrated today is an integration of clinical and genetic. This probably has the biggest data to date of utility. I think there's integration of monogenic and polygenic into a single risk marker. And there is also an integration of monogenic, polygenic with also somatic, or these variation that happen due to people's exposure and over time. And we have actually a single genomic marker that we've actually integrated. The reality is when you add those to the polygenic risk score, the incremental benefit is actually quite small. So what we observed in that study, that it was a very small increment in predictive benefit, but it's unclear if this will have actually a clinical utility. I think we need to do more studies on different methods of integrating more data sets before this could be ready for a product or seeing it as a test. So I think
Right.
that's
So
why
we're
you
we're
don't
seeing
see
that
it as
kind
a
of
test.
as where it's going, as where the future is kind of coming. Just real quick, a couple of questions, and these are kind of fast answer, I guess. Are we seeing an increase in incidence in MI in myocardial infarction in patients under 40 years recently? As an interventionalist, I'll say maybe not under 40, but I think certainly over 40, I'm seeing a bit more as kind of metabolic dysfunction and stuff are raging. Number two, I think for Dr. Fahad, you'd mentioned interventions using in the clinical trial for reversing plaque. So what, can you at a high level discuss kind of what sort of interventions outside of medical interventions, high dose statin, PCSK9, those sorts of things that you may be using in your clinical trial?
Yeah, we're using 3 interventions in our clinical trial, and these are the 3 evidence-based interventions. One is lifestyle modifications, 2 is LDL cholesterol lowering, and then 3 is anti-inflammatory therapies. So those are the 3 kind of areas of management of plaque.
Yeah, I saw you had colchicine in there, which is kind of a
Correct.
repurposed also drug. And before, the hour is kind of getting a little bit long, but there's 2 things that I wanted to make sure that we discuss, and maybe we have a hidden panelist here with us, Lindsay. As a primary care doctor, as a cardiologist, we're very used to discussing these things, but I think the conversation around genetic testing is a bit nuanced, right? And I think sometimes people are worried about, if I get a gene tested, how does that affect life insurance? How does that affect my kids and kind of all that stuff? So inviting Lindsay into the discussion as well, if you'd like. But like, how do you frame these conversations when you're in the clinic room? Because this is a nuanced conversation. This isn't just your risk went from 13 to 21. How do you approach these conversations with patients?
Well, maybe I'll take a stab at that question. I think you're right that any discussion of genetics has to think about implementation. It's something we think about very closely here at MyOme. I think this is actually a strength of the polygenic approach, which is, there's different ways of looking at someone's genetics. One way is to look very concretely at a single gene that might have really dramatic implications for someone's health, like BRCA1, but there's a whole other host of conditions like that. And there's another way, which is just to incorporate the effects of many, many different genetic changes into a single risk score. And I actually find that while that second way is conceptually more complicated, it's easier to explain, which is just you have a risk, that risk changes based on your genetics, and here's your new risk that includes your genetics. It kind of keeps the conversation on risk and probabilities in the same framework that we're used to talking about with patients, with these, especially with coronary artery disease and breast cancer with Tyrer-Cuzick. And so I actually find that our polygenic risk score approach, and probably to some degree pharmacogenetics as well, are really nicely suited for the primary care setting because that risk conversation can get wrapped into the traditional kind of conversations. Where this becomes more relevant and is probably in what we call traditional genetic testing. Those tests of traditional single genes and panels where someone has a change and they know they have the change, and that carries with it pretty substantial implications not only for the disease, like let's say heart disease or breast cancer, but a whole host of other conditions that would have to be discussed. And I think here's where our strategy is also to offer genetic counseling. And so at MyOme, we make genetic counseling available to the patients that we serve. Either people that order this test directly from our website or go through a physician all have options for genetic counseling. For the providers we work with, we give the option for genetic counseling on specific cases. Do we want to get extra counseling available for those patients who are negative? Maybe not. Maybe it's just for those individuals who have a finding on their genetic tests. And so we provide that background both directly to the provider as well as to the patients we serve.
And I think that's great having that resource available. And just a quick question, it actually came up in the comments as well. How often are you seeing people being upgraded or downgraded in their risk assessment based on the iPRS? Is it like a 1 in 20? Is it what
Yeah,
does
good
that
question.
look like?
Good question. So the way we've modeled our risk paradigm is to really focus on those people who are risk upgraded. And so in the US healthcare system, that's probably the better paradigm to use, which is identify people who may be flying under the radar who really need to get additional treatment. And so as you saw in the slides, if you look at the borderline to intermediate folks, the people that are in that 5 to 20% range, about 10% of people get upgraded into the high risk category. And those people that are in that category have about a threefold higher rate of disease, what we've seen in these retrospective, prospective cohorts. So it's not a small fraction of people that have the upgrade, and it's a pretty substantial impact for those people who are upgraded.
Yeah, Akal, any thoughts on that? Does that sound
No, I
about
mean, I
right?
completely agree. Yeah, absolutely. I think from a clinical perspective, a lot of what we're focused on is people are not in that bucket, or people not sure if they should be on statin or not sure yet. I mean, you gave the example of, should I wait a few more years? Is my risk high enough to think about it? And that's what PRS helps nudge you up. Now, think about it as a risk enhancer, and the iPRS framework is very well suited for that. I think when you're de-risking people, it becomes a little bit more challenging to provide that reassurance by the low PRS, because you have to make sure that you actually counterbalance all the other risk modifiers. So unless you have them checked in terms of risk enhancers, it is hard to give people reassurance. Unless you go through all the risk enhancers and actually have confirmed that their CRP and lipoprotein A and all the other stuff are actually low.
Yeah, and I think, as a clinical cardiologist too, very rarely would I reverse therapy, I think, because, there is some, but kind of upgrading. And finally, in our last moments, let's talk about reimbursement, right? And how to get these tests ordered, because Akash, you just kind of quickly mentioned there that there is a direct to consumer, it sounded like kind of option for testing. So, is there insurance coverage? This was asked in the Q&A as well. Like how, if we want to go through insurance, is there a code? Is there a way to do that? Is, like how do we get this test reimbursed? Or is it simply cash pay by the patient when they're interested?
Sure. First, let me be clear. All of our tests are physician ordered and mediated by physician. And so none of the tests that we're offering would be offered without a physician's supervision. Now, if you go to myome.com, you can order a test, and that test is mediated via a physician intermediary, and we have the option for genetic counseling in that situation. So to be clear, we have a CLIA-CAP lab, and everything we order is via a physician. In terms of routes to work with us, I think just to put it very simply, right now our tests are offered via a cash payment, as well as in some situations there may be certain concierge practices or other kind of boutique specialty firms who may contract with us kind of institutionally. But at the moment, our polygenic risk scores are a cash pay option. There are different routes to testing that I probably won't have time to go into in more detail right now, but in a very high level, there is one style of testing, which is to directly order a CAD PRS or iPRS, and that would be done on a certain platform, which is a lower cost that can provide that information as well as other information down the line, as well as another platform, which we call our Proactive Health Plus platform, which is built off of a 30x whole genome platform, which offers the same CAD PRS as well as additional information downstream that may not be available on that first platform. What I do is encourage anyone who's interested in learning more about our iPRS offerings to contact us at support@myome.com. We can put that link in the chat as well. We'd be happy to share more information on the different platforms and availabilities of getting access to that. What I will say in the last minutes that we do have our eye on insurance reimbursement. We do want to serve the biggest population with this type of testing, and to support that requires a different level of evidence that we're continuing to generate. As we know in the United States, the insurance system relies on more than clinical validation, but also long-term validation to be able to achieve that insurance reimbursement. And we've kicked that process off internally, and we're looking forward to being able to offer this with insurance reimbursement in the next few years.
That's great. Uncle, any parting thoughts, last thoughts on this world of rapidly evolving world of precision medicine and iPRS?
No, I mean, I think the maybe two things to maintain here. I think for our audience is that one, clinical application is already either relevant throughout the life course, early in life, middle life, or integrated risk course, and later on after development of disease. So I'd say keep that in mind. And then the second thing, the platform approach is going to be the best approach moving forward. So being able to have genetic data that could be interrogated for evolution of risk and then additional markers over time. So it's exciting really to be able to see products that start developing in both of those two directions.
Yeah, no, I totally agree. And first I want to thank everybody for spending these past 60 minutes. I feel like we could sit here for hours talking about this. Is an absolutely fascinating. Maybe we'll have a follow-up or something. But just a really cool discussion. And of course, as a cardiologist, near and dear to my heart, so to speak. Really cool. I think that, this is really technology. When we talk about myome and precision medicine, this is technology that's making doctors better and patients safer, right? And so that's really, I think, such an alignment of goals in what we all want to do in our clinical practice and with our families and whatnot. So support@myome.com is the email address. We'll send out the recording of the webinar, so we'll definitely have resources in there. For those physicians in the audience, if you are interested in learning more or being part of the precision medicine universe in a deeper way, then definitely go to ABOPM, or sorry, as you see it above me, theabopm.org. We'll have that link in the replay video as well. Learn about precision medicine. I promise you, it is not as complicated as I thought when I got in this world, and you have to start by leveling up your game, learning more, and it's just an absolutely fascinating world. So everyone, thank you so much for being here. Dr. Kumar, Dr. Vahed, wonderful to have you. And hopefully we can do this again sometime. What do you say?
Absolutely.
For sure.
Thanks for the opportunity.
All right, guys. Thanks, everyone. Take care.
Bye.
Thanks.
Bye.